Good day to all of you. First of all, I would like to thank the Mexican College of National Urology for the invitation. A great honor for me to be here today. I want to thank for the organization of this event in trying times. I want to apologize for my choppy Spanish. Today, I will talk about radical prostatectomy after active surveillance, prognostic implications. I will speak this about, I'll talk about this on behalf of our institute and our urological association. There are some items to talk about. First of all, the main series and the selection criteria for active surveillance in 2021. Then I will talk a little bit about some of the factors that may justify a change from active surveillance to radical prostatectomy. Then we'll talk about oncological results of radical prostatectomy, then the results, functional results of prostatectomy, radical prostatectomy after active surveillance, and then some of the outlooks for the future. What are some of the main series of active surveillance? There is large heterogeneity in the series. If we take into account the main series, particularly with the follow-up, we are able to see there are no more than 5 years of follow-up. And there is also some aspects that have to do with inclusion criteria. And also we can take a look at some of a couple of studies in particular where there is part of patients with Gleason 7 and other factors that were included in active surveillance, as well as some other studies where there is only Gleason 7. And also on the right hand side, we can see on the chart the safety and without treatment patients that are treatment free at 5, 10, or 15 years. Therefore, we see this is very important, and also by subgroups of group with Gleason 3 plus 4. What are the recommendations from AUA? Recommendations by EAU and active patient, particularly is low risk patient. This is Gleason under 10, also Gleason under 7, and also life expectancy of more than 10 years. Also, here we have to underline that patients with follow-up strategy, here we also see the groups that are excluded. Also, we have to take a look at the essential points of MRI, the role it plays, and also to confirm a diagnosis of as a low-risk patient. Also, we have to insist and highlight one point. There is information, and we know there is also a choice for patients. We need to inform patients so they learn about the benefits and risks of involving in active surveillance. Now let's talk about some of the main points regarding biology, PSA under 10, and we know there are some series with PSA over 10 that can also be considered for active surveillance, particularly when we are using the support of PSA of density PSA when it is below 0.15. Histology has to be used whenever possible and whenever we have access to histological tests in order to have liquid biopsies. Also, we need to select ISUP1, but also it is possible to choose in selected cases group 2, which is favorable. ISUP3 is not included. Now, right now, there is not an agreement concerning the number of cores. Also, imaging, we do not need to include patients right now with extracapsular lesion. Another point, we need to repeat the biopsy if there are significant changes in imaging, rectal palpation, or PSA. And also, we need to consider the psychological context. It is very important to take into account the family, the wife, the patient, in order to be able to be part of active surveillance. Items to discuss: what are some of the factors to justify a change from active surveillance to go to radical prostatectomy? This is a meta-analysis with 26 studies that were selected with ISUP1 and in some cases ISUP2. Initial PSA, the clinical status, an increase in Gleason score. There may be a moment of change, the change rate of treatment. What is important to note is that patients on active surveillance opted for treatment, but for different reasons. Almost 40% because of a reclassification of Gleason, 30% because of change in PSA, including also the doubling time of PSA, and 20% it was due to anxiety or the patient's choice. Another important point that we need to highlight is that this meta-analysis does not always have analytical aspects, and this is a limitation. What are some of the progression factors? This is another meta-analysis conducted particularly looking at PSA density once again, one or two more cores, and also progression, and in this study age and PSA levels were not associated to a higher risk of histological progression. This is another very important aspect, the role of MRI, in order to avoid, whenever possible, to have unnecessary biopsies, selecting patients with low grade, low risk, and the objective was to define patients that were upgrading the Gleason score 7 or higher in biopsies, and also control, and also to consider other controls. Here, when we look at PI-RADS in image, as well as the level of density below 3 or maximum 3, and whenever there is PSA density below 0.15, this was not related to Gleason score increase nor progression. This is important to highlight this item. Now, moving on, difference between systematic biopsy versus ultrasonography and targeted and systematic biopsy together with imaging. This is a prospective, randomized, multicentric study with a follow-up of at least 3 years. Almost 300 patients, one group with systematic biopsy without MRI, and the other group with systematic biopsy with MRI. Here we see that after 2 years there was a 50% reduction in failure rate in the group of active surveillance without MRI. This reinforces the value of targeted biopsy in treatment for active surveillance. Some other items, some of the oncological results of radical prostatectomy after active surveillance. Here now we have some studies. This one in particular with oncological results in the long term and follow-up. This is very important by Gottman in Sweden, with a good number of patients on active surveillance and low, very low risk or intermediate risk. And almost all the patients, particularly at the end of the study, have had MRI, which is important. This Swedish group had also delayed radical prostatectomy in 132 patients after 6 months, when they versus the initial or baseline diagnosis. And the end disease, we see there is an increase of 35% in Gleason score, 22% of extra prostate extension, and more than 0.8% of positive nodes. Significant proportion of pathology unfavorable in deferred prostatectomy, frequently not identifiable with the tumor index. This is another study that has to do with immediate versus deferred radical prostatectomy. This is a study by Ardalan between patients with low risk and active surveillance, and they were operated on because of histological progression. The other group has patients with immediate prostatectomy due to a 7 Gleason at the baseline. Then in this study, we are able to see versus the previous one, there was no difference in relapse biochemical progression at 5 years of progression. And the conclusion was that the deferred prostatectomy was not associated with adverse pathological results. This is another study, this one by Stacy Loeb, radical prostatectomy, more than 2 years, and then there is an increase in the number of Gleason grade in rescue therapy and no difference in mortality, positive margins, and extra prostate extension. This is also a particular unique study, very interesting, but we need to consider on the left-hand side, we see the selection criteria. We have patients with PSA of up to 20. We had seen others between 10 or 15, but this is 20 different versus other studies. This paper was published 2 years ago in Spain with almost 1,000 patients eligible for active surveillance with the EAU criteria. There were 4 groups. One group with immediate treatment less than 6 months, the other group more than 6 months. And then in this group there are two subgroups, one subgroup without previous active surveillance and the other group with histological progression. And here we are able to see there are 16.5% of patients that had progression, out of which 15% were subjected to radical prostatectomy. Here in this study, the conclusion is that delayed radical prostatectomy after progression had higher rates of biochemical relapse. Another study of 2 years ago, recurrence-free survival after active surveillance. This is a study from Hospital of California, almost 2,000 patients, including Gleason 1 or 2, and also with the intermediate favorable risk. There was initially 3 groups. Group 1 as a priority and 2 other groups with Gleason 2 and or at least with 2 positive cores. Here we see Gleason 2 with at least 2 positive ones. Histology, there is an increase of relapse risk, which is synonym of relapse with the increase of tumor volume. Another point of our agenda, number 4, very important, functional results of radical prostatectomy after active surveillance. We see here erectile dysfunction. The question is it justified to have immediate prostatectomy in young patients? This is a very interesting study. Almost 1,500 patients eligible for active surveillance. This study in New York, this evaluates functional erectile function, taking into account the index, and there is also a reduction of 0.25. This is the score And in the long term, there is also early erectile function, greater with immediate versus delayed radical prostatectomy. The recovery of erectile dysfunction post-active surveillance does not justify surgery in young patients of low risk. There was patients 55, 60, and there is a difference at the time of surgery. This is another study regarding recovery of erectile function and time of diagnosis to treatment of erectile dysfunction after surgery. Here we are able to see the impact of time from diagnosis to treatment on erectile function outcomes after radical prostatectomy. Here we see under 6 months, 7 to 12 months, and over 12 months of radical prostatectomy. With 800 patients, delaying surgery after diagnosis does not impact the recovery of erectile dysfunction post-op. We need to see the limitation in this study in particular regarding the size group, which is unequal under 6 months or more than 12 months. Globally, some of the psychological factors to choose between active surveillance or radical prostatectomy, here we are able to see how they consider fear to metastases by patients. This may be a reason to choose for radical treatment versus active surveillance. There is a greater concern for health in the future, and also we need to look at the importance of information of active surveillance, risks, and the possibility of receiving treatment if necessary. Another study that has to do with global drop in quality of life. This is a global life study with functional and emotional aspects. There was no significant difference among groups, except, as we can see here on the right-hand side, for social function, the feeling of reduction to relate to others, and which is important for the patients. And in the end, for the future, what is the outlook for the future to increase or to improve or to optimize patient selection and to improve the results of surgery after active surveillance? We have to think about the future. Biomarkers, we are able to see here a systematic review. It seems now that PHI and 4K are important for prognosis of an aggressive cancer. The increase GPS is synonym for higher risk of adverse pathology and higher biochemical recurrence. In the end, regarding ASCO's guidelines, there is a conclusion which is homogeneous, but we have to consider that right now these are just perspectives, it's an outlook, but we need more information to consider what can be done in our daily practice. So this information is important for the future. Last take-home messages. We have to classify strictly patients. It's important test. It seems radical prostatectomy seems not to be associated to adverse oncological results. There is no difference in the long term regarding function. There was not an improvement in erectile function. Thank you for the invitation and congratulations for the organization of this conference. See you very soon. I hope I have a chance to visit Mexico. Thank you.